Hello, good morning, everyone. Let's move on to the next question in this short answer question paper. Question number 4. This is in the field of cardiovascular studies, critical and perioperative and emergency care. Here we have a 73-year-old morbidly obese gentleman. This is very important to mention, and it's relevant. Morbidly obese gentleman presents to the emergency department with, so he had slurred speech, right-sided facial drop, and right upper and lower limb weakness. So here we have a neurological deficit or lateralizing symptoms for the past 12 hours. So here we have acute onset of neurological deficit, which is the right-sided facial drop and dysarthria and right-sided weakness or right hemiparesis or hemiplegia in the last 12 hours. On presentation, his heart rate is 89 per minute with irregular rhythms. This is very important, and it's relevant here, important to mention irregular rhythm. So we have to think about arrhythmia here. Blood pressure is 164/98, so the patient is hypertensive. This is also, it is relevant. Respiratory rate 23 breath per minute, so he's mildly tachypneic. Oxygen saturation 95 on room air, it's normal. He is currently smoker. This is relevant in the history, very important to mention, and I think it will be this information. It will be used in the management with the 60-back year history with history of obstructive sleep apnea. So the patient has obstructive sleep apnea. CT scan of the brain confirmed left parietal infarction. So the patient has ischemic stroke, and it's confirmed with CT scan left parietal infarction measuring 2 centimeter quadrant in the surface area. The ECG revealed the following. So this is the ECG. What's the finding here in the ECG? As we can see here, we have we can't figure out the P wave. So here we have absent P wave, and the QRS is normal, which is narrow QRS, and the rhythm is irregular. As we can see here, the rhythm is irregular. This R to R distance is smaller than this R to R distance, and it's different comparing to this R to R distance. So here, this combination, we have absent B wave, and we have normal narrow QRS, and we have what is called irregular rhythm. These three combination, it consists with atrial fibrillation. So here, this patient has an atrial fibrillation, most likely. And so what's the diagnosis apparent in this ECG is atrial fibrillation. So this is the answer in the short answer question. So I'm going to discuss the OSCE, the most important. I will give you an examples of the OSCE stations and how to prepare for the OSCE station. But if you are asking about what's the finding in the ECG in the OSCE station, you have to read the ECG systematically in the systematic way. You have to check the name of the patient. You have then to figure out what's the age of the patient. Then you have to start systematically, starting from the waves, which is P wave, Q wave, R, S, and T, then intervals and segments and complex. So, and after this, you will give the summary of the ECG reading. But in the short answer question, it is okay to mention just what's the diagnosis. It is atrial fibrillation. You don't need to go systematically in the short answer question. But in the OSCE station, you have to. So list 3 possible causes of this condition. 3 possible causes of this condition. So here we have risk factors, and we have here etiology. He is asking about this condition. So he's asking about atrial fibrillation. You have to be careful about this, because some students, they might think about, he's asking about the most likely diagnosis for this patient, or the most likely condition for this patient, which is the cerebrovascular accident or ischemic stroke, and he is asking about this. But Here he's asking what's the three possible causes of this condition for atrial fibrillation. The etiology of atrial fibrillation, it could be cardiovascular related causes and could be non-cardiovascular related causes. Cardiovascular related causes could be hypertension. This is one of the important things. Could be coronary artery disease, could be valvular heart disease, could be pericarditis, could be cardiomyopathy, it could be myocarditis. All of these cardiovascular causes. Non-cardiovascular causes, obesity, and our patient is obese. Sleep apnea, our patient has sleep apnea. And other things, ASD, it's related to cardiovascular. Post-operative could be sometimes BE, pulmonary embolism, COPD, chronic obstructive pulmonary disease, electrolyte disturbances. This is very important, like potassium changes, magnesium, calcium, thyrotoxicosis. This is one of the most important as well. Sick sinus syndrome. This is related to cardiovascular type of arrhythmia, and alcohol, which is called holiday heart. So this is the etiology. So he's asking about three possible causes. It could be the hypertension here in this scenario because the blood pressure is high. Could be obesity here in this scenario. It could be sleep apnea in this scenario. All of these things could be the cause of this. So here, let's investigation. Here I'm mentioning the risk factors for atrial fibrillation include the old age, hypertension, heart failure, valvular disease, especially complicated with dilated LA, electrolyte disturbances, recent cardiac surgery, lung disease, excessive alcohol consumption, hyperthyroidism, sepsis, particularly pneumonia or respiratory sepsis. Less two investigation you would carry out to identify the cause of this rhythm disturbance. The carotid duplex scan. So what's the two investigation you would like to carry out to rule out the causes or to identify the causes? So what's the other investigation? So in terms of thyroid causes, I would like to do thyroid function test, including free T4, and TSH, thyroid stimulating hormone level. This is one of the things I'd like to have. I would like to check the electrolyte, serum electrolyte, extended serum electrolyte test. Serum electrolyte, to check serum electrolytes, including the serum potassium, sodium, calcium, and magnesium. This investigation I would like to do. For example, two investigation you would like to carry out to identify the cause of rhythm disturbances. I think this is these two investigation you can mention. If you are thinking about heart failure, or you are thinking about pulmonary embolism, heart failure, you can request, for example, pro-BNP level, serum pro-BNP level, and for example, chest X-ray for the heart failure. For the pulmonary embolism, you can request for D-dimer, for example, and for example, CTBA, CT pulmonary angiography. This investigation you can carry out to identify the cause of this rhythm disturbance. So let's move on to the next. In case if we are suspecting about myocarditis or for example valvular heart disease, we have to request, for example, bedside transthoracic echocardiography, transthoracic echocardiography, or myocarditis and coronary artery disease. You can request or order cardiac enzymes. So let's move on. The carotid duplex can confirm 80 to 90% stenosis in the both right and left internal carotid arteries. So outline your definitive management of this patient, including non-pharmacological, medical, and surgical intervention, and justify your choices. So here it's very important. You have to mention and you have to answer non-pharmacological approach. You have to mention medical approach, and you have to mention surgical intervention, and this patient, for example, who has recent ischemic stroke, and the carotid duplex showed significant degree of stenosis of the left and right internal carotid artery, what's the best management in this situation? So here we have treatment of carotid artery stenosis. Generally, the decision to treat with best medical therapy alone or versus best medical therapy and surgical management depends on whether stenosis is asymptomatic or symptomatic. Our patient is symptomatic here, and size of the infarct. If the patient is symptomatic and he has infarction, size of the infarction is one of the factor. Patient functional recovery, life expectancy, and comorbidities. All of these are important factors in the decision making. So the other things you have to mention the degree of stenosis, and the degree of stenosis here he is mentioned in the stem of the questions, 80 to 90%. So he has severe stenosis. So here, for example, what's the definition of symptomatic carotid stenosis? Symptomatic carotid stenosis is defined as a focal neurological deficit referable to carotid artery distribution occurring within the past 6 months with more than 50% stenosis. This is the definition of symptomatic carotid stenosis. Ideally, surgical treatment should be done within first 48 hours to 2 weeks, within first 2 days to 2 weeks of symptoms onset. So this patient, he has these criteria. He has symptomatic carotid stenosis, and the ideal treatment here, the surgical treatment, alongside with best medical therapy. So he needs this best medical therapy and surgical management as well. So here we have the indication for medical versus surgical management of carotid stenosis. Here, so you have two things you have to ask yourself when you are treating such patient. Is the patient symptomatic or not? So we have asymptomatic patient and we have symptomatic patient. And what's the degree of the stenosis? Is it degree of stenosis mild, less than 50%, or it is moderate, which is 50% up to 70%, if it is severe, more than 70%. We have mild degree, we have moderate degree stenosis, and we have severe degree stenosis. So here in the mild cases, if asymptomatic, just best medical therapy, and even if it is a mild degree stenosis with symptomatic, also it is best medical therapy or best medical treatment. If the stenosis moderate, for example, 50 to 60%, in asymptomatic patient, it's best medical treatment. Best medical treatment. If the stenosis here moderate, but 60 to 70%, for asymptomatic patient, it's best medical treatment and surgical management if there is here prerequisite or criteria for choosing patient for surgical treatment. As well here, for moderate stenosis with symptomatic patient, it's best medical therapy and surgical management if there is a criteria for surgical approach of treatment. Our patient here, he has from 70 to 99%, and he's symptomatic. So surgical management if surgeons perioperative morbidity over mortality risk is than 3%. So I think this is the best option of treatment here for our patient, alongside with best medical therapy, best medical therapy or best medical treatment. This is very important point to mention. If the patient has 100% stenosis, that no surgical intervention, regardless if the patient is symptomatic or symptomatic. If the stenosis is 100%, just best medical treatment. So here we have non-pharmacological. Non-pharmacological is lifestyle modification. Our patient in our scenario is heavy smoker, so smoking cessation is very important. Weight loss, our patient is morbidly obese, so weight loss and dietary changes. All of these are non-pharmacological. In terms of best medical treatment, PMT or best medical therapy, it is antiplatelet agent. This is the first line. Medication. Aspirin plus minus clopidogrel. If the patient already on aspirin, you have to add clopidogrel. This confer 25% relative risk reduction. Antihyperglycemic if concomitant diabetes. Antihypertensive ACE inhibitor are particularly if concomitant congestive heart failure or renal disease. statin, aggressive management to achieve LDL reduction and plaque stabilization effect. These are the best medical treatment, PMT. In terms of surgical management, we have two options of surgical management, either carotid end arterectomy, CEA, or it could be carotid artery angioplasty plus minus stenting. Carotid artery angioplasty plus minus stenting. So carotid end arterectomy or carotid artery angioplasty and stenting for symptomatic carotid stenosis. Choosing one over the other, it's controversial. If stroke prevention is the primary outcome, so if it is stroke prevention, the primary outcome, so CEA, carotid end arterectomy has lower risk, and this is the best. Carotid end arterectomy generally is the mainstay of treatment and the gold standard of treatment. Carotid artery angioplasty and stenting indicated for poor surgical access, for radiation-induced stenosis, for comorbid patient. If the patient has comorbidities that increase the risk of surgery and anesthesia. So this is less invasive, the carotid artery angioplasty and stenting. Aggregate risk of death, stroke, or MI in peri-procedural period is not significantly different between the two, the carotid end arterectomy and carotid artery angioplasty and stenting. Higher risk of peri-procedural stroke in carotid artery angioplasty plus minus stenting. Higher risk of MI and temporary cranial nerve palsy in carotid end arterectomy. So this is how we have to justify our answer in this question. So you have to mention that the patient, he is in need for best medical therapy and surgical management. I think this patient might benefit from, or the best option of surgical treatment here, I think it is going to be carotid end arterectomy. So here we have let's move on to next question, next part of this question. So this gentleman now recovering in the post-anesthesia care unit after undergoing his procedure. So he had a procedure, either he had carotid arterectomy or he had carotid artery angioplasty and stenting. The intraoperative course was unremarkable, and the patient was extubated in the operating room after 3 hours long surgery. Shortly after arriving to the PACU, which is the post-anesthesia care unit, he became dyspneic. So here we have acute dyspnea, and his oxygen saturation 90% and acute desaturation or hypoxemia. Heart rate 115, so he's tachycardic. Blood pressure 99/68. He's hypotensive. Respiratory rate 32. He is severely tachypneic. So we have acute onset of acute dyspnea, tachypnea, desaturation, hypotension, and you notice significant swelling around the neck. So around the neck wound, around the site of the surgery, because this surgery is going to be in the neck, because he has carotid artery stenosis. So this means if he has swelling around the neck wound, most likely he has carotid end arterectomy. So he has a swelling in this side, around the wound side, neck wound. List 4 possible causes of this current symptom. In the top of the list, you have to mention what? Wound hemorrhage and hematoma. Wound hemorrhage and hematoma. This is very important. And this hemorrhage, it can lead to this can lead to hypovolemic shock because of bleeding, and it can lead as well to what is called to upper airway obstruction. So you have to mention hypovolemic shock because of bleeding, and it can lead to upper airway obstruction. Upper airway obstruction. So you have to mention this as well. Obstruction. Why? Because the accumulation of blood under the skin will compress the trachea, and this compression of the trachea will lead to upper airway obstruction and will lead to this dyspnea and hypoxia and desaturation. So here we have wound hemorrhage and hematoma, which will lead to hypovolemic shock and upper airway obstruction. This is in the top of the list. Other things you have to think about, it could be tension pneumothorax and lead to obstructive shock. It could be anaphylaxis to any of medications the patient received, either in PACU or by the end of the surgery. It can lead to anaphylactic shock. Pulmonary edema or acute coronary syndrome and this lead to cardiogenic shock could be one of the differential. Surgical emphysema, but it's unlikely to cause this hypotension and this severe tachypnea and desaturation, but it's one of the, it's not in the bottom of the list. Atelectasis as well, but it is unlikely to cause this hypotension and this severe desaturation. Atelectasis usually it can cause mild tachypnea, and usually it won't cause this level of hypoxemia and hypotension. Drug-induced respiratory failure, it could be drug-induced respiratory failure either in remaining of anesthetic. So I think in the top of the list, you have to mention this thing: wound, hemorrhage, and hematoma, leading to hypovolemic shock and upper airway obstruction. This is the most important thing to mention, and upper airway obstruction is very important here to mention. Why? Because in this question, he's testing your ability to understand or to predict the post-operative complication. So you have to mention this. Outline your approach to assessing this patient in PACU, or assessing this patient in PACU. So in terms of assessment, he's asking about assessment here. Assessment has to be in the systematic way. We have this approach, and you all know, I think, this approach, ABCD approach. And then I am fine. Here we have each letter here stands for some intervention. So A, it is airway. You have to make sure the airway is secure and open. If the airway is not secure, so you have to mention that I would like to intervene by manual maneuvers of the opening of the airway, which is head tilt, chin lift, and jaw thrust. If this manual and simple maneuver didn't help, I would like to go step up to adjunct of the airway management, which is the oropharyngeal airway or nasopharyngeal airway. If this adjunct didn't help, I would like to call for help for anesthetist, for invasive or for definitive securing the airway by endotracheal intubation or by LMA insertion. So this is how to explain. You have to explain all of this in the airway. In the B, breathing, you have to assess the breathing. You have to see if the patient is breathing spontaneously or not. If the patient breathing spontaneously, but the patient is tachypneic and our patient is severely tachypneic, you have to, and the patient is desatting, so the patient, he has hypoxemia. So I would like to introduce the oxygen therapy for the patient using titrating oxygen therapy starting from the nasal cannula, aiming for auto saturation of 94% and above, starting from nasal cannula and titrating oxygen up. Other things to consider here, I would like to assess the breathing by look, listen, and feel. This is the approach, how the simple approach, how to assess the breathing. I would like to assess the breathing by looking to the color of the patient. If the color of the patient is blue, this indicates that the patient has severe hypoxemia. So A, B, and C, circulation here very important. In circulation, it's control of bleeding here is very important. C, it's control of bleeding by external pressure. You have to do external pressure in the neck, in the bleeding side, or sometimes you have to open drainage and wound backing for large hematoma only. And I think the best thing to answer here, because you are medical students, third med, so it is called for senior help. The most important here, surgical team has to be called as early as possible, because this patient might need for exploration in the operative theater if the hematoma was large and expanding hematoma. So in the C as well, you have to put IV, 2 large bore IVs, start with resuscitation fluid, normal saline or combined sodium lactate, Hartmann solution, and you have to send routine blood test, including cross-match blood, 4 units of blood, and you can give patient antifibrinolytic agent, which is tranexamic acid 1 gram. All of these in C, circulation. The disability, you have to assess level of consciousness of the patient. If the patient level of consciousness is, for example, GCS is low, less than 8, I would consider securing of the airway by endotracheal intubation, by calling anesthetist for securing the airway. This is the D. And E, it's environment. I would like to keep the patient warm, and I would like to consider move the patient to a safer environment like HDU, high dependence care unit, or surgical ICU. And I would like to escalate the care of this patient and call for senior help, which is the surgical team has to be informed as soon as possible here. It is the IVs. And I am fine. It's monitor. You have to put monitor, oxygen saturation, ECG, and blood pressure monitor. F, it is Foley's, which is the Foley's catheter to measure urine output, and I, it is investigation and imaging, blood work, and EVGs here. I think it's important to check the gas exchange and acid base status of the patient. So this is the how to assess this patient systematically. So you have to be systematic in this. And this is the final part of this question. Hope this discussion is helpful and useful for your preparation for your exam. I will do discussion I think for preparation for the USCI exam as an orientation and preparation for the USCI exam, and I will do course as well for MCQs discussion for the past paper MCQs, and other things I'd like to do course for crash quick review for the most important topic in our module, which is the trauma perioperative and critical care medicine and emergency medicine care. All of these will be available in the teachable.com, and I will put the link for all of these courses in the description to this YouTube video. You are very welcome to join these courses, and I hope your preparation is all of these discussions and videos, they are helpful for your preparation to your final exam. Thank you very much.